My name's Miranda. I am a specialist physiotherapist, but I'm here today in my capacity as a research consultant for STEPS. Today is all about Perthes. It is Perthes Awareness Month, and today's webinar will look at Perthes, its presentation in childhood and the consequences thereof, and address some of the common questions that STEPS helpline gets. Dan, I believe, is going to present, and then Adam, and then we'll come back and look at some of the questions from the live attendees today. So I'm going to hand over to Dan and let him introduce himself.
Cool, excellent. Thanks so much. So let me share my screen, which is always the most exciting part of this. Cool. So hopefully you can see that. All good? Yep. So my name's Dan Perry. I'm a kids orthopedic surgeon, and I work at Sunny Alder Children's Hospital in Liverpool. I'm one of the professors of children's orthopedics, and my specialist interest is about Perthes disease. So way back, my PhD was about Perthes disease, and it's very much continued as my kind of key interest, both in my clinical practice and very much in my research. In terms of, I'm just going to go through the very basics. So some of you may have heard me talk about this before, but let's just recap on the basics of what Perthes disease is. So this is a nice normal hip. So this hip's football shaped. The growth plate is here, and on top of the growth plate is what's called the epiphysis. And so the epiphysis is nice and tall, and it all looks nice and healthy. On this side, we can see that the hips are a different shape. So it's flattened off. So the epiphysis, so the bit above the growth plate, so the growth plate's here, the bit above it is a bit squashed. It's a bit wider than it should be. It's kind of fragmented, so it's kind of broken up a wee bit. And just below the growth plate, in the bit we call the metaphysis, there's a wee cyst here. So there's unhappiness going on in the top of the femur. So this very much is Perthes disease, and this is what I deal with on pretty much a daily basis. So about Perthes disease. So if you're watching this, if I were to be a betting man, I'd bet your child was a boy, because it's far more common in boys. It's about 4 times more common in boys than it is in girls. That said, I obviously see a lot of girls as well, but it's very much more common in boys. And this is the reason we think it happens. We're not 100% sure, but this is what we think happens. So there's a blood vessel, which goes up to supply food, which supplies all the oxygen and stuff to the top of the femur bone. And between about the age of 4 and 8, there's a single blood vessel which comes all the way up, and it comes from the back of the femoral head to the front of the femoral head. And we think for some reason this blood vessel gets blocked off. And as it gets blocked off, it stops oxygen and all the nutrients reaching the top of the femoral head, which is what causes Perthes disease. However, we're not entirely sure why this gets blocked off. Before 4 years old, there's other blood vessels as well. And after about 8 to 10 years old, there's other blood vessels too. But between 4 and 8 years old, there's this very unique anatomy, which is why we think Perthes disease happens. And Perthes is kind of peculiar, because if you go around the world, there's different rates of Perthes disease in different places. It's very much a disease of Northern Europe. So it's quite interesting that we've got the Dutch group and we've got us English group, because that's very much where Perthes disease happens, in the northern part of Europe. But even if you look at maps of England, then you can see that down here in London, there's very little Perthes disease. And the further north we go in the UK, there's more and more Perthes disease. And if we break this down into regional pockets, we see lots of Perthes disease over in Liverpool. We see lots of Perthes disease in Hull. So we see lots of them in certain coastal towns, particularly in the UK. We'll see Perthes disease, but we're not sure why that is. It's just what we've observed from epidemiology. But what we do know is that Perthes is decreasing. So in the late 1980s, about 1 in 750 kids in Liverpool had Perthes disease. It's actually now about 1 in 1,500 or so in Liverpool. So it's getting less. But that said, it's still happening a fair amount. 1 in 1,500 is still a reasonable amount of children, and obviously you're here because unfortunately you're affected by this. So when we talk about an anatomy, so one of my old teachers used to teach me that children with Perthes disease can sometimes be described a little bit like Bart Simpson. So often they're short. So often the children that I see are the shortest children in the class. And often they're a little bit hyperactive. So they run around quite a lot. And they can be a little bit wiry as well, with slightly small feet, and their feet often don't grow before in the kind of year before diagnosis and year after diagnosis, and there's papers being written about that. So there's some kind of unusual features about the children, which so whilst it is just a hip problem, we can very much see that not all of them, but certainly a significant portion of them share these different features as well. In terms of hyperactivity, a lot of people ask me, so does Perthes cause hyperactivity, or does hyperactivity cause Perthes disease? And the honest answer is I don't know. It's a bit chicken and egg. I'm not sure whether they get Perthes disease and they get a lot of pain, and that kind of makes them respond differently and they become a bit more hyperactive, or whether they become hyperactive and that loads the hip and that causes Perthes disease. I really don't know the answer to that. But certainly there's lots of evidence to say that these kids are generally a wee bit shorter, are hyperactive, and then some people have written that they might have an association with things like hernias and undescended testes and other abnormalities around the genitourinary tract. But again, that's much more common, but certainly it's higher than the general population. So the one question I get asked all the time, and this will be on all of your minds, so is it genetic? And the way we address this is we looked at the Danish twin registry. This is my funny joke for a Danish twin registry. So we looked at the Danish twin registry. And so obviously if you've got identical twins, then they've got 100% of the same pastry, so the same genes, and they live in the same environment. And if you compare that to non-identical twins, then they'll still live in the same environment, but they've only got half the same genes. And what we did looking at the Danish twin registry is that we could see that there was no strong evidence of a heritable, so a genetic component, so it's not a genetic disease, but there is some clustering in families. And we think there's clustering in families probably because it's not a genetic cause, so there's not a gene that's causing it, but it's probably caused by something environmental, so something about the way that we live, perhaps something in the air, something kind of in our life around us that triggers Perthes disease, but we don't know what that is. And that makes more sense that there's a very slightly high chance within families, but still the chance is very low for a sibling, but it's not a genetic thing. So in terms of Perthes disease, it goes through certain stages, and your doctor's probably talked about this. And so initially, there's not a lot to see. If we look really subtly, you can see kind of a weird little shadow at the top of the femoral head here, as it just starts to, as we often will see a wee crack in the femoral head very early on. But initially, X-rays might look completely normal, and you have encountered that. And off the initial stage, it goes through the sclerosis stage, where it becomes white on top, and this is after the bone's died, and the bone calcifies, and it also flattens off, and you can see the top of the femoral head is a little bit flatter here. And then afterwards, it starts to fragment, so it starts to break up. So what the body does is the body recognizes that there's pieces of dead bone around. It eats away the dead bone, which in reality makes it look like it's disappearing. So it makes it look like there's less femoral head there. But in reality, if I was to open up the femur, so if I was to open up your child's hip, I'd be able to see that there was actually femoral head there. It was just all cartilage. So if I do an X-ray, I can't see cartilage on X-ray, but in real life, I can see the cartilage. So there is something there, but it's just squishy cartilage. And then eventually, once all the dead bone's been eaten away, the body puts new bone down, and it puts new bone down. And typically, so blood comes in from the edges. And as blood comes in from the edges, it initially gives new bone to all the side bits. And the very last portion to get new bone is that central portion. So this part here is the last bit to reform. So we go through this initial stage, then we go through the stage of sclerosis where it flattens, and we've got dead bone. We go through a stage of fragmentation when the dead bone's eaten away. So it looks like our X-ray is getting worse, but in reality, it's just part of the process. And then we go through the stage of ossification when new bone forms. And all children will go through this, and every visit, I'll look at my families and I'll speak to them and tell them about which stage of Perthes disease they're at. And generally, it takes about 3 years to get from here to here. Sometimes it's a little bit quicker, sometimes it's a little bit longer, but that's kind of an average. So the treatments of Perthes disease, and this is where it gets a little bit of a pickle, because there's lots and lots of different treatments proposed. Some are kind of the opposite of each other. So varus osteotomy is where we do this, and a valgus osteotomy is where we do this with the femoral head. So there's lots of different treatment options, and this is where the real difficulty in Perthes becomes, because you'll have lots of conflicting advice and lots of uncertainty about how best to manage Perthes disease. And so coming back to this model, so if we think about it in a very simple way, so this bit here, and this is the way I think about it. So this is my freezer cable. So this is keeping my freezer alive, and this is feeding the electricity to the freezer, and the freezer keeps this bit frozen. And so this is my ice cream, and it's in the freezer, so it's nice and hard, and it's nice and ice cream shape. And so if I turn my freezer off, then the bone squashes, and so the cartilage becomes squashy, and whatever's influencing the squashing, it is going to adopt whatever shape it's squashed into. And so often what happens in Perthes disease is that we've got the femur sitting in the acetabulum, so sitting in the socket, and as the freezer gets turned off, and the hip becomes very stiff, then the hip starts to kind of slip out of the socket. And as it slips out of the socket, the hard socket digs into the top of the femur. And as it digs into the top of the femur, it creates a wee divot. So it creates a little divot in the top of the femur. And as it digs in, it can cause a lump, for want of a better word, at the edge of the femur, which we call better a saddle lesion. So a saddle, because it looks like it's forming a saddle on top of the femoral femur head. And what that means is that if it again goes hard in this way, so when the blood comes back, so when the hip regrows, like it always does, but when it does regrow, if it regrows with this saddle, then it's going to end up with a difficult shaped hip that's not going to work like a normal hip in a normal ball and socket joint, and that hip will become painful and sore. And so you can see here that this, you can imagine that this femoral head, we've got this hard socket digging into the femoral head, and there'll be, whilst we can see this bit of bone here, you have to imagine that inside there's actually more cartilage, and that cartilage might be forming a lump here. So this hip started to escape, and we can see it started to escape because here's the floor of the socket, so the floor of the acetabulum. So this space here is quite big. I can almost put my finger in this space, whereas this space between the floor here and the edge of the hip is much smaller. So this hip started to lateralize, started to edge out, and as it's edging out, this edge of the hard socket's digging into the femoral head. So the way that we typically, or the way that I've typically approached this, well, there's different ways we can approach it. So in the olden days, the way to approach it was to put children in bed, and the way that so this picture was sent to me by one of the lads somewhere up here, and they used to go in hospital for 2 or 3 years, and they used to be put in bed, and that was the treatment for it, to be in hospital for a couple of years. And obviously that's kind of not cool anymore. You may sometimes wish that you could give your children away for a couple of years, but well, at least that's the way I feel for my children sometimes. But genuinely, I actually do quite like them and want to keep them at home. So I think that's a good thing. So different ways to approach it. Well, there's lots of different ways to approach it. And it's all about thinking about how we can best keep that femoral head inside the socket. And that's called containment. So we want to be able to say, okay, we know that femoral head's trying to escape, but I want to keep it firmly inside the socket and keep it there in the right place. So one of the ways we do that is, so some people will still use Petri casts or casts to really separate the legs, to force the hip sidewards, so abduct it and keep it into the socket. And so there's different splints we can use for that. Or other ways are to break the femur. So break the femur and do what's called a varus osteotomy, to tuck the hip right inside. Or instead to change the shape of the pelvis, to do a pelvic osteotomy, and move the pelvis over the edge of the socket. And so all of this is, I mean, they're all quite extreme. There's lots of kind of variations about how we best try and contain the hip. Or the other way to do it is to do active containment, where we say, okay, let's encourage the children with as much physio as possible, or as much physio as we think is appropriate for them, to contain it themselves. And so this is an example of one of the varus osteotomies that I've done in the past. So this is a femur that was starting to escape. I've contained. So this is in the kind of fragmentation stage when it looks like there's nothing here, but you can see as it regrows, the femoral head regrows, and it regrows into a nice round shape. So this is a fairly nice one, and this is a different operation for it. So this was early on. So my assessment was this hip was going to escape, and so instead of doing a femoral procedure in the older children, I tend to do an operation on the socket. And so I pushed down on the edge of the hip capsule. So here's the hip capsule to keep that hip in the right place. So I extended the edge of the socket. And as you can see, that we ended up with a nice round hip inside a slightly larger socket because I made it bigger. And that's called a shelf osteotomy. But the trouble is, so if we look at the best research about what's the best approach, so is it best to do surgery or not to do surgery? Well, actually, whilst I've been taught that surgery is the right way, if we look at the best evidence, it's very uncertain of what the best way to treat Perthes disease is. And part of this is because there hasn't been any really high quality studies. So I'm sorry, but surgeons around the world have never really got together to give us really good evidence. But this is a study called Herring, which people regarded as the best study at that stage. And this has got 300 children. And there was a very slightly better outcome with surgery compared to no surgery in terms of how the hip looked at the end. And we in the UK also did a study called the BOSS study. And again, we looked at about 350 children, and we showed that if you were older, so above 6 years old, your outcome was worse. If you were a girl, then your outcome, so the shape of your hip, was worse than if you were a boy. And that's probably because girls mature a little bit faster than boys, so they have less time to kind of round off the hip. If your hip was, if surgeons always believe that if your hip was stiff, then you've got a worse chance. But actually, the study showed that there was no real difference. If your hip was more affected, so more collapsed when you first saw us, then your outcome was worse, which kind of makes sense. But actually, whether you had surgery or not, well, actually, disappointingly for me as a surgeon, it didn't truly show there was any difference. But all this is observational studies, and observational studies where we look at the evidence without really testing it in a really high quality way. And a high quality way is through a randomized control study. The evidence is never particularly strong doing it like this. So surgeons obviously will always treat certain people based on their gut in certain ways, and it's very difficult to assess it through this sort of study. So if we're honest, we're not sure whether surgery makes a difference or not. My belief is, well, I do surgery because I think it's probably helpful, but I'm somewhat uncertain. And that's where the National Institute for Health Research has come into, in the UK recently, NIHR, and I'm only allowed to tell you this from 3 days ago, because that's when our contract was signed, but NIHR has just given us £1.5 million to do a study in the UK of surgery versus no surgery to definitively answer the question of what the best treatment for Perthes disease is, whether it's best physiotherapy, so best course of physiotherapy, or whether it's surgery. So on that note, I'll hand you over to Adam. Cheers.
Brilliant, thanks, Dan. I'll share my screen now. And can you see end screen? Oh, so thanks everybody for attending that. And some people who are on the call may well have seen me before on some of the STEPS webinars that we've done, and I'm here to talk a little bit more about the research side of Perthes disease. So like Dan was talking about, we've got a lot of people in the world interested in Perthes disease, and a lot of people doing a lot of work, but the one thing that we don't have is people coming together and agreeing about what to do for the best. And in exactly the same way that Dan's doing, has secured a research professorship with the NIHR, I'm currently doing my PhD in Perthes disease. And this is what my project is called, is non-surgical treatment of Perthes disease. So I'm a children's physiotherapist by background. I work in Leeds, and I'm doing my PhD at the University of Leeds to look at how we look after children with Perthes disease when we don't do surgery. So this is a little bit of an update of what we've done in the past, which the webinars are still available on the STEPS website. So to tell you a little bit more about the project, there are 3 key studies involved in it. So the reason for the project was to try and develop what we do, because what we knew beforehand was that everybody managed Perthes disease in the way that they saw best, and no one was doing anything wrong. Everyone was doing exactly what they thought was best. But like Dan said, a lot of that relied on gut instinct. So we look at those. Now we have 3 studies in this PhD where we look at planning a new treatment for it. Now it's not anything particularly new, we're just tidying it up. And that was something that I took to a young person's advisory group in Alderhay, and they decided that it should be an app. So I've been working on developing the app over the last few years, and we're just starting to get to the point where we might test that. Over the course of the PhD, I've still continued to have regular meetings with the young people, the young person's advisory group and a project advisory group who they keep me in check, and they keep me doing what I said that I would do. And here you can see some pictures on the slides of the stuff that they've done. So they designed the logo. I can't take any credit for that. That came from the experts. And they gave me the ideas about how best to complete the PhD. And also that involved me coming to some of the STEPS camps and working with Loredana and Miranda and the team at STEPS, and also speaking to you guys, the kids, the families, the other people who deal with Perthes all day, every day. It takes up a really big chunk of Dan and I's time, but it doesn't take up 24 hours, 365 days a year. So to tell you a little bit more about the study that I've been doing, the studies that I've been doing within the PhD, the first one is the planning for the app. So I spoke to a number of people. I spoke to clinicians, I spoke to physios, and I spoke to surgeons and nurses who look after boys and girls with Perthes disease, and asked them what they thought about their care that they provide for people. But more importantly, more important than that, I spoke to children and the families as well. So I had children as young as 5 years old that I interviewed, and I talked to them about the care that they've received, how they think we could do better, and then also what they thought we could do, what we could put in the app that we were planning for them. So the sort of stuff that they told us was that, and this is children, parents, grandmothers, as well as the surgeons, physios, and nurses, nobody agrees what's best. And you guys, as the families and the kids that deal with this every day, you told us that you felt that, and that we need evidence to guide the treatment. And we've tried to develop that and put that into the app. And in the next few months, we'll start testing the app and doing that to see if this is a good way of sharing the evidence that we've got now. But they told me the really important stuff. If I'm going to make an app, it can't be an app that I think is cool. It needs to be fun, and it needs to be designed by the kids and something that people will actually use and feel comfortable using. And then to do that, I need to rely on the experts, the real experts, and the kids. And I kept them involved throughout the course of that project, and doing the interview study told us a lot of really meaningful information that we're going to use within the trial and the study that Dan was talking about. But I've been able to share that at a number of different places. One of the key themes in that interview study was that families didn't necessarily feel heard, and they felt like that there was a lot of gaps in between their clinic appointments. That was like one example and that's because us as clinicians, we don't necessarily need to see you all the time because we know what will happen over the course of your care. But what we need to do is to do something to bridge that gap a little bit. And that's what the app is going to hopefully do, be a safe place for all of your information, to be the trustworthy information that we can provide you with. So then looking at how we develop the stuff that goes on the app that needs to be there. So we need to make it pretty and fun and colorful and something that you and your families will take on. But we also need to make sure that the clinical experts have had their input. So we did something called a Delphi study, which is where we gather the opinion of every specialist that wants to take part, and ours was done in the UK. So we ended up with 45 statements, which is about right for what happens within one of these Delphi studies, all relating to how we should best manage children with Perthes disease. Now, the general feeling was not surprising. It was a lot of the stuff that Dan talked about, trying to keep low impact in the early stages when that hip is really starting to break down and starting to come back, so that we've got the best possible hip environment when the hip starts to grow. And the strongest theme throughout that Delphi study was that education is going to be key to care. And the write-up for that is currently happening, and we'll hopefully have that published in the in the medical journals where we normally do, but also provide some sort of information and feedback that we'll share through things like the STEPS website and social media as well. So then on to the key part, the app. Doing that, I'm not an app developer, and I'm learning a lot, but that's not my area of expertise. So we worked with a company who's made apps for kids. They've made apps for kids in the past. So they've worked with the NIHR and they've worked with children with long-term health conditions. And it's at the early stages, but we've used all of the things that we've done. So study one were the interviews. We got children and their families to tell us what they want to see on there. So I was hoping to have some examples ready for tonight, but they've not been produced by the app company just yet. But they've got things like avatars where the kids, if they do their physio and they've done their stretches, they can win coins to be able to make the avatar. They can dress the avatar up. That's an idea that I just think is amazing, and that didn't come from me. That came from one of the kids in the study telling us what to do it. So they're the experts that we want to be involved in those. So we'll be looking to test that in the final study of the PhD, which will be an app testing study where we'll give the app to a small number of children to use and families to use, and we'll give them instructions on how to use it. But we need to find out if it works, and not if it works, if it makes Perthes better. That's there's never the aim of what we're trying to do. What we're trying to do is see if this is something that people engage with, because this is a little bit of a spoiler alert. We understand that physio is a little bit boring, and to make you engage and get on board with what we're asking you to do, we need to make it fun. And so we'll gather information about what people think. So I'll do some interviews with the people who've used the app afterwards, and we'll talk to them about what was good, what was bad. And if we were going to roll this out a little bit wider, how would we do it? How do we do this with the best, with the best things in mind for you guys to be using it? So the other beauty of this was that Dan and I have been able to share some of the research that we've been doing. And we went and spoke to, and it's great to see international people, joining us tonight, that we've been to the International Perthes Study Group and talked to them about the work that we're doing, and talking about how we're best placed to support the group with any studies in the future. So at the moment, it's watch this space, but it's great to be able to go and tell them how good our research is and what the stuff we're working towards. And even more importantly, that actually all of that comes because we've got experts like you guys helping us make sure the research answers the questions that you want answered. And so we were able to go over and talk to them about different things over the course of a couple of days. And it's really nice more to be able to tell you that there's lots of people interested all across the world in trying to make life better for people, for children with Perthes disease and the families that look after them. And then we come to STEPS then, and we're going to be doing things like updating the amazing resources that STEPS have made available for families, over the past few years. And Dan and I have been heavily involved in, producing these documents and making sure that they're accessible and useful to you guys. So again, if you think that there's something in there that you want to see, hopefully things like this webinar will be a good space for us to gather that information, and we'll keep you all up to date with this based on what we talk about. So like Dan said about what's coming next, so we're really excited to tell you a little bit more about the research that we've got coming, and what the future looks like is trying to compare whether surgery or not having surgery, and what the outcomes are of that, because we truly don't know, and this is the best way to find out. And so I'll stop sharing now, and we'll come back to Miranda.
Thank you, Adam. That was brilliant. I'm a physio and a researcher too. It was a shock when you found out physio was apparently boring to other people. So, but all this research is really important to keep that evidence-based practice up, and I do think it's relatively new that we really ask the children what they want, and making sure that we're actually meeting that need. So we have got 5 questions that have come in so far, but if people want to pop more questions in, they can do. I will read them out and then let Adam and Dan decide who should answer them. It could be both of you. The first question is whether there are any figures about how many Perthes patients have received an artificial hip at a relatively young age, and is that a monitored figure?
Okay, so we did a study a few years ago using the National Joint Registry in the UK to look at hip replacements in young people generally. And so over the course of, well, I can't remember. So you could look it up for yourself. It was published in the Bone and Joint Journal if you want the exact numbers. And I think it was called something about total hip replacements in children under 21 years old, or adolescents under 21 years old. But I think there was about 800 or so hips over about 10 years or so, in terms of young people having hip replacements super early. And some of that was Perthes disease, some of it would have been slip epiphysis, so another hip condition, and possibly a couple of other conditions. And generally, hip replacements do very well in that group of people. They can be very much life-changing in terms of quality of life. And obviously, hip replacements get better and better. So the technology gets better and better. And so while we used to say that hip replacements may last 10 years, that may not be true anymore, because it may be much longer, because they're getting much better. But the caveat is that there's always complications. There's always the potential for complications. And so whilst they're getting better and better, and they can be absolutely life-changing, you don't want to have a hip replacement until it's absolutely necessary. But at the same time, when it is necessary, I'd certainly be taking my chances with a hip replacement, because it can revolutionize what you can do. And I can think of 4 patients of mine who are all older children, so all diagnosed with Perthes, probably at 11 or 12 years old, who've had super early hip replacements, so kind of 14, 15 years old, and they've all done really, really well. And that's all anecdote, but it can be life-changing for those people.
Fabulous. The next question is if there are any known longer-term issues with the spine for patients who have a significant limp or twist the spine when the disease is very active for prolonged periods.
So in terms of long-term risks, so firstly, people often worry about, so when you're going through Perthes disease, we talked about the different stages of it. And so when you've got the stage of collapse and the stage before it regrows, everything's very swollen, and so the whole hip becomes very stiff and swollen, and that's the point where, as I said, it starts to escape, but because it's very stiff, because the bone's still collapsing, that's the point where children aren't going to move the hip, and they're going to be most twisted, and they're going to end up walking very oddly. But I think the first thing to say is that generally gets better. So as they enter the reossification stage, we expect that stiffness to resolve. We expect that to get better, and then they'll get their movement back. And that's the kind of typical process. So your child may be very stiff at the moment. You may think the stiffness is never going to get better, but more often than not, it will resolve as the inflammation resolves, as it enters the reossification stage. So if you have stiffness for a brief period, whilst it's going through that stage of perhaps a couple of years, that's not, we don't believe that's going to lead to any real long-term consequences. The other people often worry about slight leg length inequality. So you may have a leg length difference of a centimetre. As the bone collapses, it'll be slightly shorter, or if people do surgery, it'll make the bone even slightly shorter still. So you may have a leg length difference of 1 or 1.5 centimetres, but again, we don't think that leads to any long-term consequences. So my only football fact is that David Beckham has got a leg length difference of 1.5 centimetres, and it hasn't interfered with his career too much. So that's my fascinating fact about football. Aside from that, if you end up with stiffness, very prolonged stiffness for a very long time, which changed your gait, then I guess that could lead to long-term problems. But I guess potentially you'll be someone who may be thinking about other options, such as joint arthroplasty, so hip replacement, in the future. But obviously everyone's case is individual. Yeah.
The next question is whether there's any studies about the impact of poor nutrition during childhood on the development of the consequences of Perthes.
Sorry, Adam, I'm taking over. So So there were some studies done in the late 1980s in Liverpool looking at a nutritional deficiency called manganese, where they tried to replace manganese because there was a belief at the time that manganese deficiency may cause Perthes disease, because there was some evidence from animals that may be the case. But the long and short of it is that they did the studies in that, and they couldn't prove any real difference, and supplementing people with manganese didn't seem to make a difference in terms of Perthes disease outcomes. That's the only study that I'm aware of that's really looked at nutritional deficiency.
So this one might be more Adam's area. What is the recommendation at the early stages for limiting activities?
So it's a question that we get a lot of, and certainly Dan and I have tried our hardest over the last couple of years to put our heads together to be consistent in what we tell families. And it was one of the questions that was presented in the Delphi study. So we didn't just ask, Dan and I these questions. We asked, there was over 40 participants. So these are surgeons, physios, nurse specialists who work with children in Perthes around the UK. We asked them what their answer to this was. And we've come to it where we've given statements of advice that limiting activities needs to be led by the patient, it needs to be led by the family. Now, in the early stages where that hip is sore and inflamed and very easily aggravated, it seems like a really sensible and reasonable thing to ask parents to maybe not let their child go to a trampoline park if they know that they'd be really, really sore after it. Now, in the later stages, when it's not the case, and they're not sore after that, those kinds of things, the high impact stuff, then we gauge that on. But one thing that I'll very regularly tell families is that sometimes if your hip gets sore from an activity when you've got Perthes disease, it doesn't happen at the time. Sometimes it does, but typically it can be the after effect of it. It can be the after effect of high impact activity. So we talk to kids and the families about what it can almost be taking a bit of a mental log of what the aftermath of certain activities are. Because just me going and saying to a child, right, well, you definitely can't go on a bouncy castle and play football. I'm not going to be on the Christmas card list. And it might not be necessary for them, but we need to gauge that on each patient, on each child, and each family, and understanding the things like the psychological benefits and risks of stopping them doing everything when we don't know that that's the best thing to do or not. So in the earlier stages, yeah, sometimes that's the time where we really look at what we limit. But I certainly try and gauge that patient to patient.
And I do the same, and I've worked all around the world, and it's really interesting the sort of differences you see. I worked in Toronto where they put children in wheelchairs for a couple of years sometimes, and the same the same will happen in Dallas. But there's really no evidence of a huge benefit. Certainly, the psychological impact of doing that is really quite profound, and therefore I do think we need to do what Adam says and just take a reasonable step and say, look, we think that probably limiting activities may be beneficial, but at the same time, children are children and they have to be children. And so we're very pragmatic about letting children be children. And I think that's really important. And that's very much the way we approach Perthes.
Okay. The next question is about pain management. So they've said that their child has regular pain. Is there an alternative to the medications to try and manage this pain?
So sorry, will you just say the end bit again, Miranda?
Is there an alternative to the medications to try and manage the pain?
So a lot of the stuff that we could tell you about this would be anecdotal, and when I say that, it's what patients and families have told us. But we've had lots of families, certainly in my world, tell me that when they've done things like swimming and being or cycling, so exercises that don't take a lot of force through the hip joint, that they've been able to move and maybe move a little bit more and be able to take part in more, that can help with pain levels while still not doing so much of that high impact stuff through the hip, like Dan was talking about, impacting soft bone and actually doing those kinds of things. I'm a really strong advocate for the psychological benefits of these kinds of things. there's nothing worse than a child thinking that they can't be involved in what their friends are doing. So that's what we do a lot of work with in our team, to talk to families about the things that they can do, about what children can do, what they can't do. And actually, when medications are not without the risk, but we try and explore the stuff that we can do that is not just taking painkillers. And we do that by doing things like pacing. So very regularly, I'll get a family to talk to me about what their typical week looks like. And if they've got Monday, Tuesday, Wednesday, where they're doing loads and loads and loads, and then not able to do much through the course of the week, we might try and spread out those activities to lower their pain levels over the week. And that sounds really simple, but it's so effective when you look at what your activity levels are like over the course of a longer period of time.
And so to also add to that, so Adam, part of Adam's Delphi study, looked at what painkillers to use and stuff to a certain extent, and we very much advocate for using simple over-the-counter medications wherever possible. So paracetamol and ibuprofen typically. So they're both typically, for most people, very safe, used in the appropriate doses and things. We try and veer away from stronger things like morphine, because you've got to accept that Perthes disease is going to go on for some time, and therefore we need to try and not start taking stronger medications if we can possibly avoid it. When children do go through episodes of very marked stiffness, I think, like Adam says, the best thing to do is to really modify activities in those stages, and it may only be for a few weeks. So I always say, if you're in that early stage of Perthes disease, you may have been diagnosed in the last 6 months or so, and you may go through a really profound episode of stiffness. Then the natural thing to say is, okay, if someone's really stiff, what I'm going to do is I'm going to try and stretch it as much as I can to overcome the stiffness. But in reality, if you've got a really stiff hip from Perthes disease, if you think about what's happening in Perthes disease is the femoral head squashing down. And it's kind of like getting mini fractures, so like a fractured bone inside the head of the femur. And so instead of stretching it, which is just going to make it more angry, the way you actually overcome the stiffness is just to rest it for a couple of weeks, much like you would a fractured arm or a fractured leg. So if you've got an acute episode of stiffness, the best way to overcome it is just to say, okay, rather than trying to stretch it and make it more angry, let's just rest it for a couple of weeks. Either perhaps on crutches, in the worst case in a wheelchair, but just rest it and let it settle down, let it heal up, and then we can start again from where we were before.
So off the back of that, we have got a question about whether that they've had mixed advice about structured exercise, i.e. physio, versus just regular activities that they enjoy. Have you got any particular advice on that, and is it part of the research?
So we can answer the last part. Yes, it definitely is part of the research, and actually the key part of the Delphi study, what you would expect us to want to know was about exercises and stretches and what activities we would advise people to tell families about. And actually, one of the things that came up that wasn't in the first round of the Delphi, but the experts suggested it being for the second round when we went back out to ask people again, was we definitely need to tell families to follow the guidance that we would give every family to achieve the physical activity guidelines that are set by the chief medical officer. This is not information that we would change for children who have Perthes disease. We need them to be active because we know that we'd have a much bigger problem if we don't have the children reaching those same sort of milestones that others should have. And I think personally, as a physio, I definitely try and work on that with families to make sure that they have something that makes them feel physically engaged, whether that's a sports club of different ability levels or being part of something where there's some social interaction as well.
Okay, so a slightly different question now. So once the femoral osteotomy is carried out, does the bone remain in the altered position, or does it need readjusting back after a regrowth? And does this lead to any complications? Sorry.
That's a really good question. So typically there's a couple of different osteotomies we do. And so we've got a socket, a socket that's shaped like this, and we've got a femoral head that sits inside the socket. And our most common operation is to do a varus osteotomy, where we cut the bone here and we tilt the femoral head down. And by doing that, we've obviously changed the shape of the femoral neck, this bit here. We've shortened the bone a little bit because we've bent it down. And that may make the kids are already quite stiff, so they're walking slightly awkwardly, and that may initially make them walk a little bit worse. If we do this under the age of 8, what we see over time, as the Perthes disease heals, the bone actually straightens itself up. So it gains some more length, and by the age of sort of 11 or 12, the bone will look a normal shape again, or almost always will look a normal shape again. So it'll outgrow that deformity we've put in. In kids that are over 8, it doesn't do that so well. So younger kids, it remodels, so it outgrows that bend we put into it. But older kids don't do that. So in older children, what we tend to do, or at least what I tend to do, is instead of doing an operation on the femur bone, I do an operation on the socket. So I'll change the shape of the socket. So essentially tuck the edge of the socket over to stop the bone escaping, because it's not gonna, and that doesn't matter. Technically, if someone needed to do an operation in the future, that wouldn't be a problem having that extra bit of bone on the edge.
Brilliant. So then, do children who have Perthes have more chance of hip issues in adulthood?
So the short answer is yes, and it depends on the shape of. At least that's our kind of belief, and there's good evidence to suggest it depends on the shape of the hip. And we actually published something in the last few months about this. So broadly, hips can be 3 shapes. So we can end up with a ball-shaped hip, so a football-shaped hip, or soccer. Let's for our international audience, let's go soccer. So a soccer-shaped hip in a nice round socket. And that's the best sort of outcome, because we've got a nice ball in a nice socket and it moves really, really well. And those hips last, we think, for forever, or as for many, many years, until a person's at a normal age where they might need a hip replacement, because they're getting a wee bit older. The alternative is to have a rugby ball shaped hip. So the hip is still ball shaped, it's just not football shaped, it's rugby ball shaped. And so it still moves really, really well, but some of the twisting movements might not work so well because it's not quite perfect football. But it still works nicely, and it's going to last a long time, probably 40s, 50s. And the socket's kind of adapted to fit the rugby ball shape. And so that's kind of the middle outcome. And the worst outcome is having a square hip, or if not square, a hip that's got that weird bump in it that we talked about at the beginning, where the femoral head's dug in, the socket's dug into the femoral head. It's created this weird saddle. And so it's not really working like a femur anymore. This bit's just kind of, the femur doesn't quite sit down in the socket, and it's just not right. And they're the children that we think about doing hip replacements often very early. And that's only because when they start getting pain and telling us it's very difficult. So I wouldn't advocate a hip replacement early unless it was really necessary.
Lovely. Well, the next question is about expectant parents. So is there anything happening with you guys, or that you know of, to help educate expectant parents on the risk of the child developing the disease, and anything that they can do to support themselves and prepare for a child being born, or environmental factors that they can control before the child is even born?
So I think on that, so Perthes disease is rare. We're here because you guys are here because you're unlucky to have got Perthes disease. We don't really know what causes it. It's one of those things can happen to all sorts of families. So I don't, we see all sorts of things in our practice. So I don't think anyone should particularly prepare for Perthes disease. I don't think there's anything we know of that you can do to mitigate the risks of Perthes disease, other than doing all the sensible health things like having a healthy balanced diet and all of those sort of things. But I don't think there's anything we could do to prevent it earlier on. It's just very unfortunate. At least that's based on our current understanding. I'd love to know the cause, and I'm very much working with other groups to try and find out what the cause is.
So then at the absolute other end of the scale, should patients still be getting regular physio as they head into their teenage and adult years?
It's another good question. The short answer for me is no, because actually what physios are there to do is very different to for children with Perthes disease is sometimes very different to what we might for other conditions. A physio isn't someone that you should see for life, and certainly what I'm trying to move forward with and share is that we should be giving patients and families the tools to self-manage and to understand what to do on a good day, what to do on a bad day, and how to deal with that. And then we give them advice as we would with any child who comes to see me with any condition. And to be honest, anybody in any walk of life, keep yourself healthy, keep yourself as a healthy weight with a good diet, and look after yourself and keep active, and look after yourself in not just a physical sense, but in looking at more mental and social health, of making sure that you do things that keep you positive, keep you healthy in every aspect. Regular physiotherapy should only be when there is a need for it. What we tend to see as children progress to that adulthood, the Perthes disease process will have stopped. And what Dan was saying was, you'll be left with the hip that is the result of what has happened during your disease process. From that point, there might be some weakness in and around some muscles, because you might have a hip that doesn't look the same as your other hip, or wouldn't look like a typical hip. And that should be something that you might seek short-term advice from a physiotherapist for, but they would then very much be working on things like strength and activity, and really looking toward the activity and being able to self-manage what you do on a good day. So for instance, I tell my patients that if pain isn't so much of an issue, you might be able to do a little bit more, but monitor what happens afterwards. And if you're having a little bit of a worse day, like Dan talks about, take some active rest. So try and do some things that haven't aggravated in the past. And that's the same when it gets into adulthood. Working towards being active and keeping physically active is key, and still hitting those targets that we would advise every adult to do as well.
So we're coming to the last few minutes. Do each of you want to say a final piece, sum up the presentation today? I know I'm springing it on you, but if we haven't managed to answer your question in the chat, then do drop an email either back to the webinar email or to info@stepscharity.org.uk. But yeah, Adam, would you like to sum up?
Yeah, this is an easy thing for me to do. I've been fortunate enough to work with Steps now as a volunteer for, I think, probably about 2 or 3 years. And I've been to the Steps camps that the Steps team have run over the past few years, and it's a really good place for families to talk about their experiences. But also the research that I've done has taken shape based on some of the input that I've had from you guys. So Dan said that you're unlucky to be here, but we're very fortunate that you are here. Not that it's happened, but that you actually keep coming and chipping into the stuff that we do. Because on behalf of Dan and I, the research that we do is informed by what you guys have asked us to answer. So thanks to everyone, and thanks again to Steps for hosting.
Yeah, I guess for me, so we do understand, how much Perthes disease impacts your lives, and we're very much trying to work on that and address that. And and as Adam pointed out, unless you were helping us with our research, we wouldn't. None of this would be possible without your support and your help. So we really do appreciate it, and we very much try and give back to you by doing these and trying to help you through it, because we know how hard it is.
Lovely. Well, thank you both so much for being here and for this wonderful presentation. And thank you to our attendees. As I said, the webinar will be available to watch back. And yeah, if you need more help from Steps, do go on the website, contact the helpline, go on the contact forms. There are lots of resources on there. So with that, we'll close down. Thank you very much. Goodbye.